Basically, what we found in our study, we included patients with severe sepsis in the ICU, around 500 patients. In these patients that we had documented negative dipstick protein within 3 months prior to admission, and all of these patients had a serum creatinine less than 1.5, we found an increased incidence of new proteinuria measuring the dipstick. After adjusting for comorbidities and other factors that could affect acute kidney injury, we identify at least a double risk of developing acute kidney injury if, in the setting of sepsis, your dipstick changed from negative to positive. The importance of these findings is that we know that septic patients are a very susceptible population to acute kidney injury, and there is no definitely biomarker to help us in this specific population, like how to identify patients at higher risk. So if we combine all the resources we have, like urine microscopy, if you have the available any biomarker, like urine NGAL, for example, and in this case we tested the utility of analyzing your dipstick specifically for the protein component, you may identify a susceptible population to developing acute kidney injury and be more careful in monitoring these patients. Try to avoid, if you can, any nephrotoxic drug such as aminoglycoside that sometimes can be considered in septic scenarios with gram-negative bacteria, and also try to prevent other nephrotoxic that could affect the kidney, and be more careful in monitor those hemodynamics, serum creatinines, and urinary output. I want to say also that the dipstick is a test that you already have in your hospital and that you can utilize. It's simple, it's inexpensive, and is already there. So the utility of this change in protein can help you to predict some scenarios of acute kidney injury in high-risk patients, like septic patients in this case.